Blessing Ijeoma, like Ms. Gerardo said. That's my title for now. And I'm here. Many of you I have seen. Now I'm happy to be able to put names to the faces. Today we're going to be discussing this topic, polypharmacy, which is a topic of concern these days with the aging population increasing. Before we start, I think we would go through this. I'm going to need a volunteer reader. Please, if you don't mind, somebody volunteer to read this case. Yes, 1 second. Okay, we're going to do it in groups. So, let's know our groups. Who do we have? Yes, Sister Mabel, who are you? Okay. Thank you, welcome. Okay, let's start. We've been through, is someone volunteering to read that? Today the overview of what we're going to be covering is here. We're going to start with that case scenario, and in due course I will define for us what polypharmacy means and the risk associated with polypharmacy in older adults, the adverse effects. We're also going to touch a little bit, I don't know who did pharmacology here, but we're not going to go too deep into that, but it's very important for us to visit that before moving on. And then we're going to dwell more on the nursing process, which is why we are here, and what we need to do to reduce the risk of polypharmacy. We would have a free test, but first I want to present to you Ms. V, the patient in our case scenario, and I need someone to please read fast for us.
Ms. V is a 76-year-old female. Her husband, daughter, and son migrated to the United States from Poland 36 years ago. She has medical diagnosis of insomnia, coronary artery disease, hypertension, and diabetes type 2. After her husband died 2 years ago, Vicky, her daughter, became her primary caregiver. Vicky is married with 2 teenage children and works full-time. Ms. V has a health aide for 4 hours on Tuesdays and Thursdays. She attends medical daycare program on Mondays, Wednesdays, and Fridays. Lately, she has been sleeping in till noon and has fallen frequently, left gas on in the house, and goes to the pharmacy to refill her prescription with more than 12 tablets in the bottle, plus 30 day refill. When questioned by the health aide, Ms. V reportedly stated, "I don't want to run out." Ms. V is computer savvy and shops online for vitamins, diet supplements, and everything. Ms. V's life bag or brown bag has accurate list of drugs Ms. V takes: Centrum, vitamin D, E, and K, naproxen, calcium, Hyza, Benadryl, Ambien, metformin, atenolol, hydrochlorothiazide, aspirin, etc. Than she and her caregivers could give. 2 weeks ago, when Ms. V was admitted to a long-term care facility, she narrated to the admitting nurse that she had been up for breakfast that morning at 7 a.m., but did not remember taking her medications then. So at 11 a.m., I took them and went back to bed. No, she neither checked her No, she neither checked her blood pressure nor finger stick. Her health aide found her unconscious on her bathroom floor around 1 p.m. She had fallen and sustained 2-inch laceration to her right eyebrow with profuse bleed. The health aide frantically called Vicky, who activated the EMS.
Thank you. Thank you. Thank you again for reading that. That is our patient for this morning. From there, I would like you in groups, maybe groups of 3, 2s, however you feel comfortable, to quickly, in 2 minutes, list out some of the problems you can see from that scenario. Quick, 2 minutes, we're timing it. Okay, how are we doing? Okay. I need at least 5 problems that you can identify from there. Okay. Okay, number 1 group. Let's do it.
Alright, so she's depressed because she's depressed at the moment. The husband died. She's going to the daycare. The daughter is busy. She's at risk of falls because of all this medication that she's and she actually did have a fall.
Okay.
She has early dementia.
Let's bullet it. Give me problems. 4. Okay. List, bullet.
Forgetfulness.
Your credit. Okay.
Risk for
No finger sticks. She's too much over the counter medication, drug interaction.
Very good. I think we've done very well so far. And I want you to look at these pictures.
This person.
And if you do good, if you do very well, I give everyone 1 copy to go with. I'm a very visual learner, and I like hands-on, so I pass it on to you. The story, some of the things in the story is here. So if you don't remember the words, you remember the pictures. When you look at this case study, there are a whole lot of things that we as nurses can get from this. A whole lot of issues, health issues. There's another health issue or concern that can come out from this one and has come out from this one that I'm creating, but that one is caregivers' role strength. It would come out from this case study, but for the purpose of this, we're going to be looking at the area of concern, multiple drug use. So I mentioned polypharmacy, and I mentioned older adults. I also mentioned caregivers. So by my definition, older adults are people who are 65 years or older. Older adults. People 65 years or older. You can up it, sister, and put your own dates and time. And polypharmacy is multiple drug use, whether they are prescribed or not prescribed. Once it's more than one or two, that's multiple drug use. And caregivers. You and I can be caregivers to our patients, their family members, adults, or the aide. In Ms. V's case, after her husband died, Vicky became her primary caregiver. And she has her own family to deal with, so she's sandwiched between raising her mother and taking care of her young family. The health aide is also a caregiver. So the acknowledgement here goes to, you know who, Ms. Gerardo. She is my preceptor, and in agreement with my school, she has been very informative to me, and I hope I grow to, be informative to others as she has been to me. We have nurses. We don't just come up with issues or stories. We do research. We find out what's happening and how things can be improved. And this is what we're doing today, to discuss amongst us how we can better provide education to our patients, especially when you receive them and now you're discharging them. You have identified what problems they might encounter when they get home. So we would be able to teach them. There are a host of things to teach, but we can't do them on a shift, right? Right? Everybody agree? We can't do all teaching on a shift. But if we take our time to teach them one thing each time we're giving them medication, by the time they leave, they would have gained a lot of information. And then, in order to do that, you also would have to consider how they learn, the principles of learning in older adults, so that your efforts will be more effective. So this research, we found that older adults now comprise of 12% of the U.S. population. They use 35% of prescription drugs and 50% of over-the-counter medications. And the average of usage for a person over the age of 65 is like 1 to 3 over the counter. In 2006, 58% of older adults reported taking at least 5 or more medications, and 18% of them reported taking 10 or more. And what it does is also costing money and putting pressure on family members who are caring for the older adult. There are some risks when we talk about polypharmacies. The problem of polypharmacy will increase if the medication dosage is too high, or if it is incorrectly prescribed or refilled, or double dosing. And we have allied health professionals, the MDs, who prescribe these medications, and the pharmacists who dispense them. But guess what? We administer them. So whatever happens, we are at the center of care. We are responsible for whatever error occurs. So in order to reduce that, we can teach, and teach. Polypharmacy leads, no doubt, to the increased adverse effects of medications. Sometimes the older adults, not all of them, some older adults will take things just because Somebody in the daycare program said it's good. She goes to buy. It relieves my pain. She goes to buy, in addition to whatever the doctors prescribe for her. Not only that, she would go from, I'm saying she because I'm used to saying she, but it could be a male or female, it could be a Mr. V. But we're dealing with Ms. V. She goes and on, getting all the things. She's computer savvy. She gets on the computer. She goes to the pharmacy, and pharmacy says you have to fill one at a time. I want you to look at those pictures closely. That's what the pictures are telling us. You have to fill one prescription at a time. You call me to refill your prescription if you have one pill left in the bottle. So our main goal in this is to improve our own skills in the way we communicate information to the older adults. And we'll be able to empower them and the people who take care of them to manage their medications by themselves. From the case scenario, we identified some of the things that could happen due to multiple drug use. And it could be allergic reaction. They could have anything from hives, from what they purchased from who knows where. And they could be confused, which is maybe rightful side effects for some medications. But even more so if they are taking it too much and as unprescribed. We also have the risk of falls. I want to point out that Ms. V, in that case, when she was asked if she checked her blood pressure before taking her medications, the answer was no. Did she check her blood sugar before she took her medications? The answer was no. Another key thing there is that most of her medications she's supposed to take in the morning at 7 o'clock. That morning when she was admitted, she didn't remember at 7 o'clock when she had breakfast whether she took her medications. So at 11 o'clock, when she remembered, she took another dose. Possibly she had taken, so without checking her blood pressure, who knows, I want to assume that she had hypotension. Her blood pressure dropped drastically. Her blood sugar dropped because she had taken metformin and all that. So that's the wrongs of polypharmacy. Other things also, they can lead to ulcer, so many different diseases. Plus the diseases that they already have, because some of them have multiple health conditions that make them to take multiple medications. Lazaro and Pomeranz, they had a big article documenting the negative consequences that are associated with use of one or more medications. And they documented that over 100,000 deaths a year occur as a result of adverse drug reactions, making the deaths from adverse drug reaction number 4 leading cause of death in America. 3% to 7% of all hospital admissions in the United States are for treatment of adverse reactions to drugs. The most consistent risk factor for this adverse reaction is the number of medications being taken. And the risk for the adverse reaction increases as the number of the medication they take increase. I had a chart there. I took it off because each time I did it, it wasn't coming clear. It wasn't showing me. I didn't know how to do it anyway. So I took it off. But what was going to be on the chart, I was going to depict with the chart that the more the number of the medications, the more the risks. Other risk factors we've touched. Ms. V have had multiple health conditions, multiple medications. He has a prior history of adverse reaction. And now, as the population of older adults is growing, we are going to have even more work at hand. I don't know who here works with older adults. All of us. Okay. At one point or another, if you don't work with them here, you have them at home, and we ourselves are getting older too. We are getting older, sister. That one I know for sure. Okay. Okay. We identified here some of the drugs that are most frequently associated with adverse effects. They are psychotropics, antihypertensives, diuretics, digoxin for heart, and some of the non-steroidal. Ms. G, what's that?
Who can say NSAIDs?
Yes, NSAIDs, okay.
No, but what does it stand for? It's just
non-steroidal.
No, what does NSAID stand for? It's not arthritis.
NSAIDs, non-steroidal anti-inflammatory. Thank you. There you go.
Who got that? We don't have
Shade. Okay. When we talk about pharmacokinetics, this is referring to what the body does to the drugs. And the body absorbs medications, the body distributes it, the body metabolizes it, and the body excretes it. So here we're saying that normal changes in those processes that occur with aging increases the risk of adverse medication reactions among the elderly or the older adults. The elderly is at risk for toxicity at doses considered normal for younger people. Excretion. Medications, of course, some of them are eliminated through the kidneys and, of course, the urinary system. So age-related problems with the kidney can greatly affect how the kidney is able to or unable to excrete the drugs. So if they are not excreted, they remain in the body, and so toxicity can ensue. We're talking about pharmacodynamics. This one now talks about what the drugs do to the body. And in general, the lower the doses are required to achieve the same effects with advancing age. The reason is because receptor numbers, affinity, or the receptor cellular affects many changes with age in a homeostatic mechanism. And these two can increase or decrease drug sensitivities. But the most commonly used list is what is called a Beer criteria. Beer has a criteria that he published, and that includes 48 PIMS, potentially inappropriate medications for which there are more effective or safer alternatives for older patients. That was reported by FIC and others in 2003. So, but Rabel, Charles, and Dugan and other people are saying that despite the criteria, all the things that are, it says studies in the last 18 years has found that, studies have found that potentially PIMS, potentially inappropriate medications continue to be used in 12% to 40% of older adults in community and nursing home settings. Rothberg and others also had administrative data from 400 hospitals across the United States that they checked out, and that study reveals that nearly half of all older adults who are hospitalized for 7 or more common conditions were prescribed at least one potentially inappropriate medications. That means that the polypharmacy can arise from several factors. It can arise from the people who are prescribing it, the doctors. They may not have knowledge of the right medications for geriatric group. And also, it can be that they add drugs to what they are taking without checking them. It may also be that the patients are shopping from 2 different or more doctors so that they don't tell Dr. B what Dr. C had given them. So Dr. C ends up giving them the drug in the same family. So she now takes atenolol and takes Pindol, whatever blood medication each doctor gave them. When you take them together, that's a crisis. So the influence, they said that patients are usually influenced by what they see on TV. It can help me. So they go and they search on the internet, they get it. They forget sometimes to not take it with what was prescribed. They don't ask questions sometimes. And that's how sometimes the older adults get in trouble. They fall. They end up in the hospitals. And the cost, the money increases. Other things also may be because they have access to healthcare. They have money. So each time they fall, they have a place to go. Each time they see something they like on TV, they get on the internet, they buy it, they have money. That also can be the reason why they are not complying with medication for those who do not have. So as this will increase polypharmacy, on the other hand, it would increase non-compliance. They're not taking medications because they cannot afford it. They can fall and get up. Nobody is calling them and taking them to the hospital. They may not have their family members who care as much to take them to the hospital. So as we go ahead, when we receive our clients, one of the things that the implications though for us is that we have to deal for all this. We are the eyes for the doctors. We are the eyes for the advocates for the patients. We have to counsel them. We have to research to find out information for them which is appropriate for their age. We have to teach them in the ways that they can understand, so that if they are older adults who don't want to read, they can have pictures like that and hang it wherever on the cabinet. So as they come in, we first ask them for what they are taking at home. You may find list and list that they are able to list, but something came up. I think they have something that is called the brown bag. Ms. V calls it the life bag. That's where she has all her medications prescribed and unprescribed. So it would be a good thing if when they're coming from that bag, you can see that their list of what they're telling you is shorter from what the bag contains. So, I just thought about the life bag. There's a huge research on, they call it brown bag. When I was putting this together, I saw that it's called brown bag, but in families, people call it, they know what they call their stuff. Yeah, their stuff. But they're saying as nurses, whenever they come in, you just take the brown bags and one by one review what the medications are, so that you'll be able to at least assume and imagine, like we did in that case study, what problems that we are able to resolve. Sometimes being on multiple medications contribute to patients not taking those medications as prescribed. We said that. So it is very important for us to recognize the roles that physician and the patient factors play in non-adherence to medication. The patients may not report their symptoms properly. They may use multiple providers. We've been all through that. They may be forgetful, so that they take more than they're supposed to have. They go to the pharmacy, they refill their medications before it runs out, so they have two medications that are the same in the bag. They take one, and then it can be very chaotic unless they get education. And the public is depending on us to teach and teach and teach. These are further the nursing interventions. I think as we are discussing, we've gone through all this. So we are saying that it's also important to recognize additional factors that lead to the medication. We talked about money, we talked about increased number of medication, we talked about the brand name, the trade name, everything mixing together, Aleve and all those, and the route also. We talked mainly about our reason for being here is to be able to deal with the knowledge deficit that leads to polypharmacy. The patient, when they are changing their medications, let's say they came in with the medication of atenolol, or let's say Ambien, for instance. She already has Ambien. Is there any need for us to recommend to the doctor to give them Benadryl? It's the same effect. There will be no need. So if you're on Ambien, stick to Ambien. Or doc, did you know that this lady is on Ambien? So when you call the doctor's attention, they will listen to you usually. They will say, oh, is she really on Ambien? So I don't need to give her Benadryl. Or is she on this atenolol? I don't need to give her metoprolol, whatever the case may be. As nurses, we need to examine our own knowledge about the dangers of drug-drug interactions, because in order for us to teach, we have to have the knowledge. If we do not have the knowledge, we won't be able to convey knowledge. You can only give what you have. So very important it is that we can always have our colleagues as resources. Let's say you have a patient who's going home. If you don't know how to teach, we can be resources for one another. Not knowing how to teach, but the interaction is very important than saying words. They learn by you giving them pictures. Those will be yours, like I said. And it will only be in the case of a patient like Ms. V. So you create something else for each patient. Individualized, none is the same. Miss V is Miss V. You're going to get Miss B or Miss A. So when you assess them, you'll be able to understand who they are and you teach them from that point. It's very important for us to, when we're teaching the older adults, it's very important for us to remind them not to change the way that they take their medications. Sometimes it's very good to educate both the patient and the caregivers so that they can work together even at home. So there are some things here that you can ask them just to ascertain how much they know about their medication. You can ask them if they know the names of their medications, if they know what they use the medication for, what times they take them, or how the medications make them feel. Because sometimes they go shopping for something else because of how what they have make them feel. Very, very important. You are taking this, how does it make you feel? You might say, when I take it, I feel nauseous, my stomach is messed up, so I don't want to take it anymore. I'm going to take this one. So that's when they start to make irrational decisions about what to take, and that's what brings about going to buy multiple medications. When somebody says, I don't know, I need to drop whatever I'm doing and make them know. So, the nursing intervention, like I said, it never ends. It's uncountable, it's numerous. You can never finish teaching because you don't know. What's going to happen is unpredictable, but for that particular pill you are about to give, for that particular medicine that you are about to send them home with, it is very, very important that you let them know how to use it. For example, if you are giving her metformin, she's diabetic, you can also ask her, do you check your finger stick? Very important. Before you take this, Ms. V, check your blood glucose. If it's too low, do exactly what the doctor says to do. Take it as prescribed and don't create your own method. If you have any problem, discuss it with your doctor. They might change it, increase it or decrease it or take you off completely. Same as antihypertensives. If you give them blood pressure medications, you must remind them to check their blood pressure each time. And another thing is, for some of the older folks who may be forgetful, we all forget sometimes. Sometimes I don't even remember, oh, did I take this pill this morning? Has that not happened to anybody here? It happens to me. So if it happens to me once or twice, it might happen to older adults even more. So you say to them, if you don't remember, call your doctor. Don't take it until you are sure. Or you can check your own blood pressure. If it's too high, you know that you may not have taken it 7 o'clock. Because by 11 o'clock, if it was high at 7 o'clock, you took it, it should be able to come down a little bit. So, any questions, comments, critics, anything, answer? Yes, Ms. McEwen.
One of the major things, though, with the elderly, we have to keep remembering to do is when the patient goes to the doctor and the doctor decides to change that medication, there's a tendency for the patient to continue to take the old one and the new one.
Yes.
So it's something that we have to, if we have, say, a community type patient that you're following through, to check those medications to make sure that the discontinued one is not in the life package, as you say, in that brown bag, okay? Because a lot of times the discontinued one is there, and you're taking that plus the new one. You have to be mindful of that.
Yes, thank you. I have the pre-test before we go into further discussion, because what I just did, this is the end of the session, but it is the beginning of our discussion. We're going to use 5 minutes to discuss this, and before we discuss, I need you to take those tests. It is not relevant to assess older patients' mental status. Okay. Older adults use multiple medications to treat themselves because they do not have access to health care. False. Thank you. False. The higher the number of medications taken by older adults, the higher the risk of true. During discharge planning, nurse should ask doctor to prescribe Benadryl. False. Okay, the most practical method of medication adherence assessment for most elderly patients may be to interview the patient caregiver using open-ended and non-judgmental. True. During admission, nurse must ask patient to provide list of medications. Thank you. Nurse must use his or her judgment to identify those medications and dosage which the patient is likely to continue taking after discharge.
No question is not clear.
Nurse must use
his or her
his judgment
to identify those medications.
Absolutely true, because then if they can identify, they can speak with the doctor about it.
Yes.
So it's true.
Yeah.
Remember, what's perfect, like,
Talk about it. What's truth? What do you think? Okay. Truth. You must use your judgment at all times. If nurses communicate at least a piece of information to patients each time they administer medication to patients, it can help to prepare for safer care after discharge. It's true. We talked about that. All the answers. We cheated. Only older adults are at least. Okay. Good job. Older adults are at higher risk. Okay. Number 11, I just want to highlight that it is not only the older adults that are using multiple medications to treat their illnesses. It's just that it's common amongst them. Okay. Questions, comments, critics. Anybody has something to say? What could we have done better? There are a lot of things we miss. There are a lot of things we did not discuss. From your experience, can we share some information, what you think may be a barrier to effective patient teaching in your unit, in your facility? Do you have policies? Okay, Sister Maybe.
What's the implication for privacy and between the residents and the caregivers, teaching the caregiver what medications the resident is taking?
What is the answer to that? Which caregiver? Family caregiver or professional?
The home health aide. Yeah, because in some instances you find it's the home health aide who is going to be at the point of discharge,
Yes.
with the resident.
Okay.
And is it legally right, or is there privacy implication, HIPAA implications, teaching the home health aide what?
I know.
Who has the answer? Who has the answer to that? Who has the answer?
I wouldn't say you should teach the home health aide.
You have to teach them.
You can give them printed materials to take home, but they can't do that. But you shouldn't be teaching them.
But what do they do? Are they not supposed to help with the medication?
Okay.
No, they
What
can't,
do they do?
no, they can't pour it, but if it's pre-poured, they can give it to them.
Yes.
So then you just teach them for side effects. That after Mrs. B takes this and you see this, please call 911 or then call me. The primary, caregiver.
Okay, well, consider the fact that The agency sends different home health aides each time, so it's not going to be the same person that will be there all the time.
Okay, that's what I'm saying, they have
So that means-
printed materials that lists the side effect of every medication, posted somewhere in the home.
Okay, just.
No, if that
But you know
case, the nurse has to come in and
somebody's
report that medication. The nurse has to report that medication. Yeah, the nurse has to come in and report. Yeah.
She checks all the clients and she educates the patient and the patient.
Okay, Mabel, you also raised the issue of privacy. I want to let you know that the home health aides have trainings. They are trained, they are in our team, they are part of our team. Even if they change them, their agency will train them on what to do and what to report to home care nurses. You remember that you send them home, and if they have coverage, they come. Like the home health aide in Ms. V's case, the agency sent her there for 4 hours every Tuesdays and Thursdays. And you also remember that the aide was the one who found her on the floor and was able to give some vital information. So the aides are part of us. As for primary care, Vicky can pre-pour her mother's medication. There is a box. I have one of the boxes.
Yeah, the 7-day ones.
They have either 7 days or, so you teach your patients to, once you see that there is no medication in that hole, that means you have taken it. So there won't be any need to confuse whether you have taken it. That will reduce the risk for double dosing or overdosing. Questions?
Besides teaching, right? First of all, remember discharge planning, right? Discharge planning, which is part of our role. And one of them is just medications. So this is where you start. So when you're saying, like nursing practice, so you assess the resident, the caregiver, and then there's the reason why they coordinate the home care person to go over and see what are the needs in the community, right? And that's how we coordinate the care. So it's very important that when we're doing that, we do this part. You assess, right, in order to do that. The one other comment I want to make here is in terms of reducing rehospitalizations, what are we doing? In terms of polypharmacy. We spoke about polypharmacy here. I use a lot of medications. What are we supposed to be doing to reduce rehospitalization for our own residents here?
Reduce use of
What happened, John?
Medication review.
Reducing, but first of all, when they are here, right? Admission, readmission, as she says, is to make sure we have, right now they do have what they call a medication reconciliation, knowing all the types of medications they have. Right? Yes, the nurses do that. Very good. So if they are doing that, this is the reason why we are focusing on the knowledge gap, the knowledge of the staff in terms of what medications. Remember we keep saying, if they don't know the medications, don't go ask Mrs. Gerard or Lee. In your signal. Because I don't know 1,000 meds either. The only reason, sorry. The only reason I have this is because in your Sigma you have that little blue with the little top on that says drug information. And you should be able to read that and see what is the most important thing for the residents. So, but this is how we can reduce our rehospitalization by knowing the medications your residents are on and teaching them. This is just one of, Blessings just did a good job in doing polypharmacy. And from here onwards, besides making a critique of what she has done, we have been so busy with operational issues, the day-to-day. The charts we have to review, the documentation we have to review. But I believe that what we would need to energize our staff and ourselves is the same way we're doing it. Is probably, you can come up with once a month grand rounds on your unit so that you energize the staff, right? Because this is the only way we keep updated, so we don't go to the day-to-day, oh, we're gonna do the reviews, we have to do this. After survey, maybe we can go over back and have like your grand rounds, making sure you appoint someone, you know, like one of you can do the same type of presentation to enhance your presentation skills, right? To be able to facilitate them. So if we're able to assign that and make your listing, we will then prioritize. This was just a good segue to our plan for after survey anyway, because we are so into the day-to-day. Did you do this? Did you do this? Did you do this? Did you do this forever and forever? But instead, we should really go back and energize ourselves to our own professional growth as well as your staff. Again, so we can either do ground rounds, resident assessment, can go and say this is CHF, this is how we prevent it, this is how we, you know, go over and do documentation. So let's go over, especially for those who are into going back to school, and for all of us, presentation skills is always a good skill to have. So if you do, you know, we can start that around September, right, Miss Monica? So that we can have one rounds and you can encourage each other. We can have laughter. We used to have this lunch and learn. So we'll bring it back so that this way, you know, we can do all this little enterprise. Huh? Bring your own lunch. Remember, the monies are tight. Bring your own lunch. The laughter is free, but bring your own lunch. All right, so thank you, and please, any comments on blessing, on Ijeoma? This was, as I said, a good segue. Please give her a critique to how the presentation was. It will go to be part of her grade. So whatever you have, please make a comment. It's really not, as I said, I am serious when I say, let's please start sometime in September when the survey is finished, to go back and assign each other and do a group, whatever group things you need to do. This will enhance all our skills also. It will enhance our knowledge too. We should really be going back to evidence-based practices, right? So anything that you have on the unit, like your HIV population, you have a lot of evidence-based, right? So if we can have evidence-based practices here, we can publish, we can promote, you can be at conferences, you know, so that's what we do, what we need to do. That you can use me as a resource, but not every single drug. So we can all do that, all right?